Welcome to the April IJGC Conversations, the editor's choice, where we explore the latest research in gynecologic oncology. I'm Stephanie Gill from the University of Toronto.
I'm Elise Yates from Houston Methodist. Today, we're excited to share some key takeaways from the April issue of the International Journal of Gynecological Cancer. We've pulled out 3 really interesting articles that touch on risk stratification, recurrence patterns, and exciting new biomarkers.
Absolutely, Elise. These papers offer some fresh perspectives and potential challenges to current thinking in managing gynecological cancer. Let's jump right in with the first one.
Our first article is titled Effect of Substantial Lymphovascular Space Invasion on Location of First Disease Recurrence and Surgical Stage 1 Endometrioid Endometrial Adenocarcinoma. This study looked at patients with surgical stage 1 node-negative endometrioid endometrial cancer.
Right. Lymphovascular space invasion, or LVSI as I'll refer to it, is something pathologists look for. It's the presence of tumor cells within blood or lymphatic vessels. We know LVSI can predict nodal spread and recurrence, but how much LVSI matters? And where does the recurrence happen? That's what this multi-center retrospective study aimed to clarify.
They defined LVSI based on the WHO criteria, focal meaning less than 5 vessels involved on at least one pathology slide, and substantial meaning 5 or more vessels involved. They looked at over 1,500 patients with about 11.8% of those patients having some degree of LVSI.
The headline finding is pretty significant. They found that just having LVSI detected, regardless of the extent, was associated with a 3-fold increase in the 5-year cumulative incidence of failure for recurrence compared to patients who had no LVSI.
But they also dug into the location of recurrence based on the extent of LVSI. This is where it gets really interesting. They found that substantial LVSI was a significant prognostic factor, specifically for distant recurrence. Patients with substantial LVSI also tended to have other high-risk features like grade 3 tumors and deeper myoinvasion.
And importantly, they looked at focal LVSI separately. So when comparing patients with focal invasion to those with no LVSI, they found that focal invasion was associated with a 3-fold increase in failure rates for both local and distant recurrence.
So Stephanie, how do you think this is going to impact current treatment?
This really has direct implications for current staging. The FIGO 2023 staging system groups no LVSI and focal LVSI into the same risk category. The findings from this study suggest that focal LVSI and no LVSI do not actually share the same prognostic outcome. So their results actually challenge that part of the FIGO 2023 classification.
Awesome. So moving on, let's look at the second article. This one is a review focusing on circulating tumor DNA and endometrial cancer, clinical significance and implications. ctDNA, or circulating tumor DNA, is a hot topic right now in oncology.
Absolutely, it really is. This review points out that while ctDNA is a promising, non-invasive tool and a useful biomarker in many tumor types, data on its clinical utility, specifically in endometrial cancer, is still limited.
The basic idea is that tumors shed DNA into the bloodstream, which can be detected through a simple blood draw, often called a liquid biopsy. This is less invasive, less time-consuming, and potentially less risky than traditional tissue biopsies. Plus, it can capture the heterogeneity of the tumor, even in different locations.
The review explores several potential uses for ctDNA in endometrial cancer. One is risk stratification and prognosis. Some studies have shown that detectable ctDNA is associated with clinical pathological features of tumor aggressiveness and has been observed with reduced disease-free survival and overall survival. Preoperative detection has been linked to advanced stage, deep myometrial invasion, and LVSI in some studies.
Another exciting area is early detection of recurrence. Because ctDNA has a short half-life and is often cleared quickly after surgery, detecting it postoperatively could potentially indicate occult microscopic residual disease. Some studies suggest ctDNA might even detect recurrence earlier than traditional methods like imaging or CA-125. Undetectable ctDNA after initial treatment has been associated with prolonged recurrence-free and overall survival.
The review also mentions the potential for ctDNA to help personalize adjuvant treatment by guiding decisions on treatment escalation or de-escalation. It could also be used to monitor response to therapy and potentially for screening in high-risk populations, such as those patients with Lynch syndrome.
But it's not without challenges. The review highlights the lack of standardized protocols and assays. Factors like tumor shedding rates, location, and load can affect detection. There are also issues with false positives and false negatives, and the cost of sophisticated analysis like NGS.
Exactly. While NGS appears to be the most suitable detection method for its comprehensive analysis, it's also more expensive than PCR-based tests. The review notes that there's still no consensus on ctDNA level cutoffs for clinical relevance.
Despite the limitations and the need for larger prospective studies, there are ongoing clinical trials exploring these uses for ctDNA and EC. It clearly holds significant promise as a non-invasive tool for better managing EC patients.
Awesome. So our third article for the month focuses on improving how we grade endometrial carcinomas before surgery, specifically looking at grade 2 tumors. The title for this article is Improving Preoperative Binary Grading, Relevance of P53 and PR Expression in Grade 2 Endometrial Carcinoma.
This is crucial because getting the preoperative risk stratification right is really important for deciding on the best surgical approach, like whether to do lymph node assessment. Current FIGO grading is 1 to 3, but there's also a move towards a simplified binary system, low grade and high grade.
The problem is that morphological grading alone can be tricky. About 14% of preoperative grade 2 endometrial cancers are actually upgraded to grade 3 after surgery. So if you classify all grade 2s as low grade preoperatively, you really run the risk of undertreating those that are actually high risk.
So, this study looked at whether adding immunohistochemical markers, specifically P53 and progesterone receptor or PR expression, could improve that preoperative risk assessment for grade 2 tumors. They hypothesized that P53 wild type and positive PR expression in grade 2 tumors would be linked to better outcomes.
They merged the data from 3 large European cohorts, including over 400 patients with preoperative grade 2 endometrioid carcinoma with known P53 and PR status. They compared their outcomes to patients with preoperative grade 1 and grade 3 tumors.
And their findings strongly supported their hypothesis. They found that preoperative grade 2 endometrioid carcinomas with wild type P53 plus positive PR expression showed similar survival to grade 1 endometrial carcinomas. These behave like low-risk tumors.
And on the flip side, preoperative grade 2 endometrial carcinomas with aberrant P53 expression and or negative PR expression showed survival similar to grade 3 endometrial carcinomas. They behave like high-risk tumors.
This is a significant finding because it suggests a modified binary grading system could be applied preoperatively to grade 2 tumors based on their P53 and PR status. So instead of lumping all grade 2s together, you could potentially split them into low risk, being P53 wild type PR positive, and high risk, all other categories.
Ultimately, the study emphasizes that this approach uses low-cost, widely available immunohistochemistry, making it a practical option, potentially even as an alternative to more expensive molecular testing for stratifying these grade 2 tumors.
While it's a retrospective study and couldn't replicate previous findings on reducing postoperative discordance with this algorithm in their merged cohort, the prognostic value of combining P53 and PR in grade 2s was clear. It definitely provides strong support for refining preoperative risk assessment within this group.
Awesome. So to quickly recap the highlights from these 3 articles, the first study on LVSI tells us that even focal LVSI matters and has different recurrence patterns than no LVSI, challenging current staging.
The review on ctDNA shows its potential as a powerful, non-invasive tool for risk assessment, early recurrence detection, and personalizing treatment in EC, although more research is needed to overcome current limitations.
And the third study offers a practical, accessible way to improve preoperative risk stratification for grade 2 endometrioid cancers by using P53 and PR expression, effectively splitting them into low and high risk groups with outcomes similar to grade 1 and grade 3, respectively.
These papers really show the ongoing efforts to refine our understanding and management of endometrial cancer, moving towards more personalized and accurate approaches.
Exactly. It's fascinating to see how research is constantly pushing the boundaries. So this wraps up our look at some of the key articles from the April issue of IJGC.
Yes, thank you for joining us.
And we'll be back soon with some more updates from the IJGC.